Assalamu alaikum. This is Dr. Rania Hamza, anesthesia consultant. Now we are discussing the second part of the lecture we have already started about diabetes mellitus and how to manage diabetic patient preoperatively, intraoperatively, and postoperatively. This time we are going to start with hypoglycemia. Hypoglycemia, in which blood glucose level less than 4 millimole per liter, is the main danger to diabetics. Perioperatively, fasting, recent alcohol consumption, liver failure, and septicemia commonly exacerbate this. Characteristic signs are tachycardia, lightheadedness, sweating, and pallor. This may progress to confusion, restlessness, incomprehensible speech, double vision, convulsions, and coma. If untreated, permanent brain damage will occur, made worse by hypotension and hypoxia. As for anesthetized patients, they may not show any of these signs. Monitor the blood sugar regularly and suspect hypoglycemia with unexplained changes in the patient's condition. If hypoglycemia occurs, give 75 milliliter of 20% glucose over 15 minutes or 150 milliliter of 10% glucose, and repeat the blood glucose after 15 minutes. Alternatively, we can give 1 milligram glucagon IM or IV, or 10 to 20 grams or 2 to 4 teaspoons of sugar by mouth, or an nasogastric tube is an alternative. Now let's discuss the variable rate intravenous insulin infusion. The recommended first choice solution for VRIII is 0.45% sodium chloride with 5% glucose, and either 0.15 potassium chloride or 0.3. However, this is not always available. 4% glucose and 0.18% sodium chloride, 10% glucose or 5% glucose are acceptable. Whenever giving hypotonic parenteral fluid, beware of hyponatremia. Preferably give 10% glucose at 60 milliliter per hour rather than 5% glucose at 120 milliliter per hour to prevent water overload, particularly in the elderly. If potassium is less than 4.5 millimole per liter, add 10 millimole potassium chloride to each 500 milliliter bag of glucose. Start the VRIII using syringe pump. Adjust according to the sliding scale. Test blood glucose hourly. Initially, parents on more than 100 units of insulin daily will need higher doses of insulin by infusion. Now let's start discussing the VRIII sliding scale. It seems complicated a little bit, but let's break it down. It is adjusting the insulin infusion rate according to the level of the blood glucose in millimole per liter. So here is in the blue color the blood glucose in millimole per liters, starting from 4 to 7 to 9, 11, 14, 17, 20, and more than 20. Okay, those written in pink color, this is the initial rate of insulin infusion. So for instance, let's start in case of we have less than 4 millimole per liter glucose. We start by 0.5 or even 0 if a long-acting background insulin has been continued, and treat as for hypoglycemia. In case it is the glucose range from 4 to 7, so we'll start the initial infusion rate of insulin by 1, and so on. Then what is written in green, it is the insulin infusion rate if blood glucose is not maintained less than 10 millimole per liter. Okay, again, this is unit per hour. So this is unit per hour, and the green also unit per hour. Okay. So for instance, if the glucose level is from 7 to 9, we start initially by 2, and then if the blood glucose is not maintained less than 10 millimole per liter, we shift to 3, and so on. If the blood glucose level is more than 20, you have to check the infusion running and seek diabetes team or the medical advice. In case we are transferring from the variable rate intravenous insulin infusion to the subcutaneous insulin or the oral treatment, how do we do it? In case we are restarting oral hypoglycemic medication, we have to recommence the oral hypoglycemic agents once the patient is ready to eat and drink. Be prepared to withhold or reduce the sulfonylurea if food intake is likely to be reduced. Metformin should only be recommenced if estimated glomerular filtration rate is more than 50 milliliter per minute per 1.73 square. Restarting subcutaneous insulin for patients already established on insulin, the conversion to subcutaneous insulin should be delayed until the patient is able to eat and drink without nausea or vomiting. It should take place when the next meal-related subcutaneous insulin dose is due, for instance with breakfast or lunch. Restart the normal pre-surgical regime. Beware that insulin requirements may change due to the post-operative stress, infection, or altered food intake. Consult the diabetes team if blood sugar is outside the acceptable range, which is 4 to 12 millimole per liter, or if a change in diabetic management is needed. Ensure the overlap between the VRIII and the first injection. Ensure overlap between the VRIII and the first injection of the fast-acting insulin. The fast-acting insulin should be injected subcutaneous with the meal, and the VRIII discontinued 30 to 60 minutes later. As for patients on basal bolus insulin, if the patient was previously on a long-acting insulin analog such as Lantus or Levemir, this should have been continued, and so the patient only needs to restart their normal short-acting insulin at the next meal. For patients on a twice-daily fixed mix regime, the insulin should be only reintroduced before breakfast or before the evening meal. For patients on continuous subcutaneous insulin, you can commence the subcutaneous insulin infusion at the normal basal rate as long as it is not bedtime. VRIII should be continued unless the next meal bolus has been given. As for the ICU admission, you have to manage the patients admitted to ICU postoperatively to ensure blood glucose between 5 to 10 millimole per liter. Previous evidence for tighter glucose control, 4.4 to 6.1 millimole per liter, leading to improved mortality and morbidity, has not been borne out. This showed no difference in outcomes, but significantly more hypoglycemia and the need for more nursing input to achieve this level of glycemic control safety. Now let's shift to another regime, which is known as the GKI or Alberti, or the glucose potassium insulin regime. This is an alternative, simpler regime which does not require infusion pumps but may produce less accurate control of the blood sugar. The original regime, as described by Alberti, consists of 500 ml of 10% glucose plus 10 millimole of potassium chloride plus 10 to 15 units of soluble insulin, all added to a bag of 500 milliliter. And this provides insulin 2 to 3 units per hour, potassium 2 millimole per hour, glucose 10 gram per hour if this runs or is infused at a rate of 100 ml per hour. Glucose 10% is not always available, so the following regime with 5% glucose can be used. Infuse 5% glucose, 500 milliliter bags at the calculated rate for the patient's fluid maintenance requirements. Insulin and potassium should be added to each bag as per this diagram. The bag may be changed according to 2 hourly blood glucose measurements. As we see here, this is the level of the blood glucose units that we have to add according to the blood glucose level in millimole per liter. So for instance, if the blood glucose level is 4 to 6, so you have to add 10 units. 6 to 10, you have to add 15, and so on. As for the potassium chloride, if the potassium level is less than 3 millimole per liter, so you add 20 millimole potassium chloride. If the level is from 3 to 5, you have to add 10. If more than 5, you don't have to add anything. Here is a summary of the perioperative management as for the glucose level and how to manage it, because I found out that it might be a little bit perplexing, so I did this diagram from the lecture itself. Rapid sequence induction and regional we have discussed before. Then, according to the starvation, if it is short starvation, you just modify the regime of the insulin or of the oral hypoglycemic as we discussed before, and better to use Hartmann's solution. You check the glucose. If it is above 12, you check the ketones. If it is 3 plus or it is very high, so you stop or you cancel the surgery. Actually, if the ketones are okay, then you can give the insulin subcutaneous according to it is. If type 1, give 1 unit. If type 2, give 0.1 unit per kg. If you are in a hurry, so you can start using the VRIII. If the starvation is long starvation, then you have to go to the VRIII. An alternative to the VRIII, we said it is the JKI or the Alberti, and we have discussed how to do it with glucose 10%, and you add the potassium and you add the insulin. If you will go for the VRIII, you have to use insulin and glucose, and the best concentration is 0.45% sodium chloride and 5% glucose if this is available. If not, you can use saline 0.18, glucose 4 or 5 or 10, and of course 10 is a good option. Then after finishing the VRIII and finishing the procedure, you want to shift back either to oral insulin or to subcutaneous insulin. If you're going to shift to subcutaneous insulin, the injection of insulin has to be given 30 minutes before you stop the VRIII, and you have the options of either the patient is on basal bolus regime or fixed mix regime or continuous subcutaneous regime. The insulin should be taken related to the meal, and there should be overlap with the VRIII. The infusion has to be stopped after you give the injection by 30 minutes, and avoid giving it starting it by bedtime. That's it. That's the whole thing about the managing diabetic patient pre, intra, and post-operative. Now we conclude the second part and conclude the whole lecture. So I hope really you benefited, and till we meet next time in the following lecture. This is Dr. Rania Hamza, anesthesia consultant. Okay, salam alaikum.